I start with the name of Allah, the Lord of Mercy, the Giver of Mercy. I'm Dr. Muhammad Yusuf Hawan. I'm a consultant physician working in NHS UK. This is my fourth lecture on localization of neurological lesion. In the first part, I discussed about localization of neurological lesion in unconscious patients. In the second part, localization in the conscious patient based on anatomy of the brain and the spinal cord. And third part, I discussed localization of neurological lesion based on the vascular supply of the brain and the nervous system. In the last part, this current lecture, I'll discuss localization of the neurological lesion in the peripheral nervous system. Right. So I will start with a question as usual. 72-year-old male presented with difficulty in swallowing. Examination revealed wasting in small muscles of the hand and feet. Tendon reflexes were depressed all over. There was no sensory loss. What is the most likely diagnosis? Peripheral neuropathy, motor neuron disease, cervical nerve compression, myasthenia gravis, or left MCA, so stroke, left middle cerebral artery stroke. So you can pause the video as usual and think over it, and we'll come to this question after a few minutes. So for localization of neurological lesion, naturally, we really need to remind ourselves of the neuroanatomy. So we have already discussed these figures in the previous lectures. I'll just briefly go through this one again to remind you what we had already discussed and how it compares with the peripheral nervous system and how it helps differentiating the brain lesion from the peripheral nervous system lesion. So remember this one. This is the pathway, the motor pathway, or we can call it corticospinal pathway. It starts from the precentral gyrus, and through the precentral gyrus. You all know that the whole body is represented like the leg on the medial side of the hemispheres, and then the arm and the hand and the trunk and the ham and the face. And these corticospinal fibers come down, are quite really condensed in here, lower part of the coronary artery, and then from the posterior limb of the internal capsule coming down to the midbrain, through the pons, through the middle oblongata, and then most of the fibers decussate to the opposite side, forming the lateral corticospinal tract, and some of the fibers continue in the same on the same side, forming anterior corticospinal tract. And this figure tells you the orientation of the motor fibers and the sensory fibers, and then the visual and auditory pathways. So the same thing, but this is the sensory system. The sensory fibers from the foot and arm, the sensory fibers go through the dorsal root ganglia, enter into the spinal cord through the posterior horn cell, and then through the cross to opposite side and form the corticospinal tract. And this form goes to the thalamus, and from the thalamus goes to the posterior central gyrus where the sensory cortex lies. So on this side, some of the fibers, like I'll just discuss in subsequent slides. So that from the foot and the arm, foot and the hand, go through the dorsal root ganglia, and these fibers go through the posterior column rather than through the anterior column, coming out to the anterior column. So this will go through the posterior column and go up, and then decussate to the opposite side, and then again terminate in the thalamus, and then go to the posterior central gyrus, postcentral gyrus, to the sensory cortex. So anterior spinal thalamic tract, this tract, this carries the sensations of touch, temperature, and pain. The posterior column fibers. These carry sensation of the joint position sense, vibration sense, and half touch. So if you think when you're going through the sensory examination, we'll not go into the examination of the sensory or the motor system. But if you find that there's a problem with the vibration sense or the joint position sense, think of the posterior column region. But when there's a problem with the touch, temperature, and pain, then probably these are the problem with the anterior spinal thalamic tract. So again, the same, the same text. So I'll not go into the details, but so we remember that. So from when we discussed the perimeter tract or the corticospinal tract, so the motor fibers, they terminate on the anterior horn cell. This here. This is the anterior horn cell, and these are another neurons are located here in anterior horn cell. These are lower motor neuron, and the fibers from the corticospinal tract from the precentral gyrus to the anterior horn cell, or those fibers are called the upper motor neuron, because those are the axons of the neurons present in the precentral gyrus, and those are called the upper motor neurons. And the fibers from the anterior horn cells, that's this part of the spinal cord to this part of the spinal cord through the motor root to the muscle. These are the lower motor neurons. So from the anterior horn cells down to the muscle, the fibers which are carried from anterior spinal root to the peripheral nerve to the muscle. These are the anterior horn cells. So the sensory route from the sensory receptors on the arm and the foot and the hands, so from this to go to the posterior, through the peripheral nerve, go to the posterior horn cell, and from here, the second order neuron either from opposite side or then to go up through the spinal thalamic tract. So from precentral gyrus down to the anterior horn cells are upper motor neuron, and from anterior horn cell, the fiber go to the muscle. These are the lower motor neuron. So clinical examination can help you in differentiating the lesions of the upper motor neuron from the lower motor neuron. We'll discuss in subsequent slides. So look at this picture again, the same thing from the peripheral nerve of the hand, the sensory fiber, the sensory fibers, the green fibers coming through here, peripheral nerve to the posterior root ganglia, the sensory neuron, to either the start the second order neuron from here or to the opposite side and cross to the opposite side of the spinal cord and go up to the thalamus, and from thalamus to the postcentral gyrus. And the motor neuron from precentral gyrus to the anterior horn cells, these are upper motor neuron, and from the anterior horn cells to the muscle, these are the lower motor neuron. So we can localize the lesion in the peripheral nervous system, starting from the spinal cord lesion to lower motor neuron, and then the dorsal root or the ventral root lesion, they're called radiculopathies, and from there go down to the peripheral nerves, and then the neuromuscular junction, and then the sensory and the motor receptors, and then the muscles, which are the end organ for the nervous system. So, and any examination from the lower motor neuron lesion to the muscles and the subtotal level of the spinal cord, this is called the peripheral nervous system. From lower motor neuron, so sensory or motor, to the peripheral nerve, through the neuromuscular, through the dorsal or ventral root, through the peripheral nerves, to the neuromuscular junction, to the sensory receptor and muscles. So this is what is called the peripheral nervous system. Right. When I mentioned about the upper motor neuron lesion, the lower motor neuron lesion, so the difference between upper and lower motor neuron lesion is the weakness will be present in both types of lesion, whether it's the central or in the peripheral. But in upper motor neuron lesion, there will be no wasting. But in the lower motor neuron, the muscle will be wasted and there will be fasciculation and the twitching movements of individual muscle fibers, which is sometimes visible. So these are the features will differentiate between upper and lower motor neuron lesion. So the weakness is present in both types of lesion, but the wasting and fasciculation is present only in the lower motor neuron lesion. Tone is decreased in the lower motor neuron lesion, but is increased in upper motor neuron lesion, and the upper motor neuron lesion and the pyramidal tract lesion can cause increase in tone, which cause spasticity, as opposed to the rigidity, which is extrapyramidal tract lesion, but the tone is increased. This is that from the perspective of upper and lower motor neuron lesion, tone is increased in upper motor neuron lesion, while it is decreased in the lower motor neuron lesion. Tendon reflexes are depressed in the lower motor neuron lesion, but increase or exaggerated in upper motor neuron lesion. And the planters are upgoing and upper motor neuron lesion, whereas downgoing or equivocal in the lower motor neuron lesion. And superficial reflexes will be present in upper motor neuron lesion, but absent in lower motor neuron lesion. So the wasting, decreased tone, decreased tendon reflexes, downgoing planters, and absent superficial reflexes. These are the features which are suggestive of lower motor neuron lesion. So weakness with wasting, decreased tone, decreased tendon reflexes, downgoing plantar 3 days, remember 3 days, and absent superficial reflexes. These are the features of lower motor neuron lesion. But if the weakness is there, but there's no wasting, tone is increased, muscle are exaggerated, tendon reflexes are exaggerated, planters are upgoing, and the superficial reflexes are present. These are the features of upper motor neuron lesion. That means that in the lower motor neuron lesion means from the lower motor neuron and the anterior horn cells of the from the anterior horns of the spinal cord to the muscles. That is lower motor neuron lesion. And upper motor neuron lesion is from the precentral gyrus to short of anterior horn cells. So coming back to our question, so the patient with difficulty in swallowing, examination revealed wasting in small muscles of the hand and feet, tendon reflexes are depressed all over. There was no sensory loss. So these are the features of lower motor neuron lesion. And because this is a pure motor deficit, there are no sensory loss. That means the anterior horn cells, the motor anterior horn cells are involved. And this is one of the specific disease. It's called motor neuron disease, which can affect the anterior horn cells specifically in the spinal cord. And it's involved the brainstem and that can affect your swallowing and speech, dysphagia and dysarthria. So question 2, 62-year-old female presents with weakness both the legs, progressing over last 3 months, no history of headache or blurring of vision. On examination, muscle power is 3 or 5 in both the legs, that is decreased. Tone is decreased in both the legs. Tendon reflexes are depressed in the legs. Planters are bilaterally downgoing. Pain and temperature sensations are depressed or decreased up to knees bilaterally. The rest of the clinical examination is normal. So as compared to our previous patient, this patient has all the features of lower motor neuron, but in addition to that, there's some sensory loss below the level of the knee. So what is, which imaging study is likely to be most informative in this particular patient? CT head, MRI head, CT whole spine, MRI lumbar spine, or nerve conduction studies. Right. So this again, the revision of the same thing. I'll go back before we answer this question. So whenever there is injury to the hand or when the pain receptors are stimulated, so sensations are taken from the peripheral receptors to the peripheral nerve to the posterior through the peripheral nerve to the posterior root, dorsal root ganglia, posterior nerve to the opposite side of the spinal cord, and ascending pathway, the spinal thalamic tract, to the thalamus and to the posterior central gyrus. So with this limb, that if we find that sensations are depressed or absent up to certain level, then probably we need to know what is the level of the spinal cord which is affected, up to what level. This which can explain the absent or decreased sensation below that level. So we really need to know the level of dermatomal supply by the spinal cord. That this figure illustrates something, the basic of something, the neck fiber from C3 to C4, by but the deltoid part of this one is supplied by the C4, and then the C5 and the lateral side of the arm, and then the C6 is the lateral side of the forearm, and this one is thumb and index finger, middle of the finger, that's the C7. And this middle side of the forearm is a C7, and then the upper part of the middle side of the arm is upper arm is C8 and T1, and then upper part of the thorax is T1. From, if you remember the nerve supply, the dermatomal supply of the arm, then you see the level, which level, up to which level the sensations are absent or impaired, then we can make out, or this part of the spinal cord is involved. So from the, if you look at the thorax, so from up this from the spine, sorry, from upper part of the thorax up to rib cage level, this applies from T2 to T10. From lower part of the chest, for the rib levels, to the umbilicus is T10 to T12. From the umbilicus to the inguinal region is T11 and T12. So this from T2 to T10, upper part of the chest, I mean the chest, from T10 to umbilicus is the T12, and from umbilicus to the inguinal ligament is T12 and L1. So the inguinal region is L1, and then this anterior thigh L2 and L3, and then down is the medial part of the leg is L4, and the lateral part of the leg is L5. This is properly distributed on this side. So the L2, L3, and L4 going out down to the medial side of the lower leg, and L5 the lateral side of the leg, and S1 is from the back. This part, this is this side is L1 going up to L2, and this perineum is L2, 3, 4. So from this level, for this knowledge, you can localize the lesion in the spinal cord. Let's see how. So upper limb from C5 to T1, something up to T2, sorry. Upper limb C5 to T1, lower limb L1 to S3, perineum is S2, 3, 4. So tendon reflexes are there's the tricep, brachioradialis, bicep, and the triceps, and knee jerk and knee reflex and ankle reflex. So the best way to remember this thing, start from the lowest part. The ankle reflex is supplied by the S1. Knee is supplied by the L2, 3, and 4. The brachioradialis, this one, is supplied by C5 and 6. Bicep is supplied by C5 and 6, and the tricep by C6 and 7. So L1 foot, L2 knee, L3 wrist, L2, 3, 4 knee, C5 and 6 is the wrist or the brachioradialis, C5 and 6 the biceps, and C6 and 7 is the tricep reflexes. So from L1, L2, 3, 4 knee, C5, 6 brachioradialis, C5, 6 the biceps, and C6, 7 is the triceps. If the reflexes are some of the reflexes, suppose the knee reflex is present, but the ankle is absent, the lesion is between L4 and S1. All right. So you can make out from this knowledge that which part of the spinal cord is involved. So two ways to detect the sensory level, muscle supply, and the tendon reflexes. That will help you in localization of lesion in the lower motor neurons in the peripheral nervous system. So coming back to our question, so 62 years old female presents with a weakness, both legs, progressing over the last 3 months, no history of headache or blurring of vision. That this information rules out intracranial problem or something, because you know that if there is a lesion involving medial side of the both hemispheres can cause the weakness in the both the legs. So probably it's not the upper motor neuron, not from the brain. It's something down lower in the nervous system. And examination, the muscle power decreased, tone is decreased, tendon reflexes are depressed, and plantars are bilateral going. These are the lower motor neuron features. And I'm sorry, this says now the nose says there is sensory loss below the knee, as we given in the next. This is some a clerical error in this question, but there was sensory loss and below the knee. So what was the best investigation? That will probably be the problem. The below the knee mean at the knee level is L2, 3, 4. That's the lumbar region. So the best investigation is MRI lumbar spine. So why the other questions are wrong? The CT head, we know the there's not problem in the brain because there is no headache or no information given indication of the cerebral involvement. MRI head is not the first investigation. Usually when the CT head is not informative, I will go for MRI head. So CT whole spine could be done, but to be more specific is the lumbar region problem. So below L2, 3, so MRI lumbar spine is the best investigation in this patient. Nerve conduction studies are done when there's a problem with peripheral nerves or neuromuscular junction or the muscles. Question 3. 72 years old lady presented with abnormal gait, weakness of legs, and numbness of both feet. These symptoms are gradually worsening. On examination, muscle power is 4 or 5, both legs, mild weakness, tendon flexors are depressed in the both legs, joint position sense, and the vibration senses are absent in the feet. So the additional information here is the hemoglobin is 98, MCV 116, and P12 85. So what do you think? Where's the lesion? So mild muscle weakness with tendon flexors are depressed in the both the leg, that's been lower motor neuron, something not the anterior not corticospinal tract, the pyramidal tract are not involved. So the joint position sense and vibration sense are absent. So which part of the spinal cord take these sensations? These are the dorsal root ganglia. Dorsal columns. Dorsal column take the information about the joint position sense and the vibration. So this is some problem with the dorsal column or the posterior column of the spinal cord. So which part of the spinal cord is involved? Ventral part of the spinal cord, anterior horn cells, posterior horn cells, dorsal part of the spinal cord, or lateral spinal thalamus tract. So we just go through this picture, right? So anterior part of the spinal cord contains corticospinal tract, the pyramidal tract. So any problem with the anterior part of the spinal cord will cause the muscle weakness with the increased tendon flexors, increased tone, the upper motor neuron. So, and then if the lateral spinal thalamic tract are involved, this one. So this tract carries the sensations about the touch and pain and the temperature. So this part is, if anterior part of the spinal cord will involve this, these are the tracts which will be involved. So ventrospinal thalamic is again the touch, temperature, and pain. The lateral spinal thalamic with touch, temperature, and pain, and the pyramidal tract that will cause the muscle weakness and upper motor neuron signs. So these are the features of the damage to the anterior spinal cord. With the posterior spinal cord, these are the fasciculus gracilis and fasciculus cuneatus that they call the dorsal white column. So these are the tracts which carry the sensation about the joint position and the vibration and half touch and some two-point discrimination. So probably this part, the dorsal horn cell, dorsal column of the spinal cord, this is the correct answer. Again, that this part, ventral horns, again the ventral root, the spinal nerve to the peripheral nerve, and the dorsal root, the ventral root and the dorsal root, they combine together to make the peripheral nerve or spinal nerve. And this is the dorsal column, which carry the sensation for vibration and joint positions and two-point discrimination. So coming back to our question, these are the sensations which are carried by the posterior column. And this thing, MCV, high MCV and low beta, probably this is a condition which can specifically involve the dorsal column of the spinal cord, a condition known as subacute degeneration of the spinal cord. So dorsal part of the spinal cord, that is the correct answer. So if the problem with the spinal cord itself, so see which part of the spinal cord is involved, and that the basic anatomy will help you localizing the lesion in this part, any part of the spinal cord. The ventral cord, means corticospinal tract, the pyramidal tract, depends upon the level, the proximal, the upper, the weakness, hyperreflexia, muscle spasms, and extensor plantar responses. And the sensory level will be according to the level of the spinal cord which is involved. The distal cord and the lower roots, the cardiac vena, lower limb, cardiac vena involvement of the perineum with retention or incontinence of urine and feces. So with damage to the lower spinal cord, especially S2, 3, 4 area. So lower limb weakness, decreased muscle tone, and areflexia. And the dorsal spinal cord will cause ataxia, loss of joint positions, and vibration, and two-point discrimination, light touch below the level of the lesion of the spinal cord. This is a specific condition which is called amyotrophic lateral sclerosis, and why I've put this slide here just to let you know that sometimes you can have combined signs of the upper motor neuron and lower motor neuron lesion. So combination of upper motor neuron sign or hyperreflexia, spasticity, that means increased tone, extensor plantar reflexes, and the signs of the lower motor neurons are atrophy of the muscle wasting, fasciculation, and areflexia or absent reflexes. And this one specific condition, part of type of motor neuron disease, is amyotrophic lateral sclerosis, which can cause both upper motor neuron sign and the lower motor neuron sign. But then there will be nerve sensory deficit, and there is bulbar involvement that they will result in difficulty speaking and swallowing. So next question is 45 years old male presented with right leg pain and lower back pain, which he developed 2 weeks ago while moving furniture at his home. Also complains of numbness right big toe and the lateral side of the right foot. No history of fecal or urinary retention. Some sensory loss in the right foot. Straight leg rising sign, restrictive movement of the right hip, no spinal tenderness. Rest of the clinical examination is normal. So what is the most likely diagnosis? Fracture L4, 5 vertebra, lumbar muscle spasm, nerve root impingement L4 and 5, referred pain from the acute appendicitis, and right renal or ureteric colic. Right. The correct answer is nerve root impingement. I will come back to this answer again once we're going through what's called radiculopathy. Radiculopathy is the problem with the nerve roots, pathology of the nerve roots. Nerve roots, there are 2 types, the dorsal nerve root and ventral nerve root, which are coming out from the spinal cord, and then they combine to make the peripheral nerve or the spinal nerve. Then the lesion in this particular area, the nerve roots can cause pain if the cervical or the neck area nerves are involved. They cause the pain in the cervical region and arms. And if the thoracic spinal cord is involved, thoracic nerve roots are involved, pain in the thoracic area, and the lumbar nerve roots are involved, will cause pain in the lumbar area and the legs. They will cause the weakness, the numbness, and the tingling in the nerve distribution area, and the wasting of the muscles supplied by those nerve roots. And there will be dermatomal sensory loss with that particular area supplying that part of the skin will have the sensory loss. So the nerve root involvement, why are the other answers wrong? The fracture, 4 or 5, because there should be spinal tenderness with the fracture or whatever. There is no spinal tenderness. And lumbar muscle spasms, again, those some spasms, but there's no tenderness over there. And the referred pain from the acute appendicitis is usually not referred in this distribution. Right renal or ureteric colic, they have the pain referred from your lumbar region to the inguinal region. So this particular part, the involvement of the LR4 and 5, and then there's some numbness in the lateral part of the foot and the big toe, and the pain that is restricted, the straight leg rising sign are the classical features of nerve root impingement in the L4-5 area. So next question, 65 years old female, history of diabetes, hypertension, and hypercholesterolemia, presents with progressive weakness, numbness in the hand and feet, sometimes associated with burning. No history of trauma. Clinical examination reveals diminishing sensation in the hands and feet. Hands and feet. What is the diagnosis? Radiculopathy, nerve root compression, peripheral neuropathy, myasthenia gravis, or motor neuron disease. The radiculopathy would discuss the specific nerve roots are involved, and it can affect those particular parts of the arm and the legs supplied by those nerve roots. But the symmetrical distribution of pain and numbness in the hands and the feet is probably not the feature of peripheral nerve root or the radiculopathy. Myasthenia gravis is the problem of the neuromuscular junction, and this the patient has the weakness in the muscles, and the motor neuron disease is motor neuron anterior lower motor neuron anterior horn cell problem, and there's no sensory loss. So probably it's the involvement of the peripheral nerve, because the patient has the history of diabetes and hypercholesterolemia and the symmetrical distribution in the both arms and the legs, both hands and the feet. So probably the diagnosis is a peripheral neuropathy. So then what happens in peripheral neuropathy? Pain, paresthesia, weakness, or autonomic dysfunction. Distribution of the sensory motor deficit is symmetric versus asymmetric, but usually is in both the sides. Sometimes the distal nerve root, distribution may be the distal or the proximal, depending upon the cause of the peripheral neuropathy, may be focal or generalized if one nerve is involved, or systemic disease is involving most of the nerves in the body. The pathology could either demyelinating or axonal damage to the peripheral nerves. Size of the nerve fiber involved, the large versus small nerve fibers, that's probably clinically difficult to differentiate. So that is what will be the feature about the peripheral neuropathy. And for peripheral neuropathy, usually look for the systemic causes. Question 6, 35 years old female presents with a generalized weakness, double vision, and bilateral ptosis. Symptom worsen during later part of the day. What is the most likely diagnosis? Peripheral neuropathy, fifth cranial nerve palsy, myasthenia gravis, Eaton-Lambert syndrome, or spinal cord compression at C5 level. So the key information in this question is about muscle weakness, which worsens during later part of the day. And this key information is probably the most specific about the myasthenia gravis, the disease of the neuromuscular junction. So the weakness, the ptosis, and double vision the usual presenting features, and the features are worsened during the later part of the day when the neuromuscular transmitters are depleted, and that will result in worsening of the signs. So peripheral neuropathy, to the symmetrically, but no relation to the time of the day or night. Fifth nerve palsy will cause the nerve problem only in the face, not in the arms and the legs, and is usually unilateral. Eaton-Lambert syndrome, I will discuss, is opposite to the myasthenia gravis, and the features improve during later parts of the day. And the spinal cord compression at C5 level will cause paraplegia, and sensory level below C5. So the neuromuscular junctions, specifically there's the two main diseases named to remember. One is the myasthenia gravis, and this presents with ptosis, mean drooping of the eyelid, and diplopia, double vision. These are the first manifestation in most of the patients. Muscle weakness, including dysphagia, difficulty in swallowing, and shortness of breath. Normal deep tendon reflection and sensation. Symptoms worse in the later parts of the day. On the EMG, when they would repeatedly stimulate the nerve and the muscle, that there will be decremental responses to the repetitive stimulation on EMG. So these are the features typical of myasthenia gravis, and this is the disease of neuromuscular junction. So Eaton-Lambert is opposite to the myasthenia gravis. There is muscle weakness, but it improves in the later parts of the day, and there will be incremental response to the repetitive stimulation on EMG. So this on EMG is opposite to what we have seen in myasthenia gravis, and mostly this syndrome is associated with malignancy and considered as part of the paraneoplastic syndrome. So I hope it's the last question is 16-year-old boy is brought to the hospital with gradually progressing difficulty in getting up from the chair. He also complains of difficulty coming in here. On examination, there is wasting of the shoulder and the hip muscles. There is no sensory loss. Tendon reflexes are normal, and the plantars are downgoing bilaterally. So what is the most likely diagnosis? Peripheral neuropathy, proximal myopathy, distal myopathy, motor neuron disease, and lumbar spondylosis. So the diagnosis here is proximal myopathy, and the classical features about the class. This has the weakness, the wasting, and the muscle tenderness, and normal sensory and reflex examination. So the proximal muscle weakness will result in, the difficulty in combing the hair, difficult proximal muscle movements, and in the lower limb, difficulty getting up from the chair, and difficult from standing from the squatting position. These are the features of proximal muscle weakness. And the distal muscle weakness, probably you have the motor neuron, just wasting of the small muscles of the hand and the feet. That's what is called the motor neuron disease. Creatine kinase and will be raised, and EMG will be more or less helpful in diagnosing part of the myopathies. So if if you go back, what all we have discussed so far. So if you can localize the lesion from the muscle, neuromuscular junction, peripheral nerve, from peripheral nerve to the root, nerve root, dorsal nerve root, the ventral nerve root, and then anterior horn cells and posterior horn cells. From there, the spinothalamic tract or the corticospinal tract downward. If you know the basic anatomy, neuroanatomy, and their function, so it will be very easy to localize the lesion in any part of the brain. And the previous slide are going up to the brain, and then from the cortex, subcortex, brainstem, so the level of spinal cord. So if you are confused, you have done a very good clinical examination, but you are unable to localize the lesion on the clinical features alone, and you think there's confusing findings. So think of three things. So multiple sclerosis, amyotrophic lateral sclerosis, and syringomyelia. So multiple sclerosis, we have that by definition, there are two different lesions, different parts of the brain and different parts of the time. So that may probably will not be able to definitely say, oh, this part, maybe some parts, some lesion you'll be able to localize, but maybe mixed lesion probably. So the mixed signs will be difficult to diagnose clinically for the multiple sclerosis. So if you're confused, think of multiple sclerosis and go for the MRI brain, MRI spinal cord. Amyotrophic lateral sclerosis, we already discussed that we have the mixed upper and lower motor neuron signs, and this is a type of motor neuron disease. So you can have upper motor neuron sign as well as the lower motor neuron sign. Think of the amyotrophic lateral sclerosis. Syringomyelia and syringobulbia, these are the cavitating lesions. It's part of the brain and brainstem and the spinal cord. So you can have different signs, confusing signs in this condition. So we'll not be able to diagnose, but we will need diagnostic imaging. There are other diseases, neurological diseases, which we don't show up on the clinical side, on imaging studies, but you can diagnose only with clinical examination. And these are mostly the motor neuron, movement disorders. Movement disorder you can diagnose only by the clinical examination. Usually the imaging studies will not be very helpful. So remember, there is no shortcut to clinical examination in neurology. And with good neurological examination, you should be able to localize the lesion in more than 80% of the patient. So these are the different levels of the brain we discussed in all these 4 lectures. So this was all about so localizing the lesion. That means where is the lesion? That's the first question you ever asked by your examiner, or you are encountering your real life patient with a neurological problem. Think about a clinical examination. Where is the lesion? And once you have localized the lesion, then think of what is the lesion and what is causing all these problems. And that's the end of this series. And next series, we will start with the working on what is the lesion, or so what are the diseases which is causing the lesion. And the first part of those lectures will be cerebral vascular disease. So thank you very much for viewing this video. I hope this series will be useful for you, and we'll wait for the next series about other diseases of the nervous system. We'll be discussing in our subsequent lectures. So any feedback, this is my email, and you can find the link on this on the YouTube as well. So thank you so much, and take care.